Good afternoon, teammates. This is Dr. B and our teammate Nate. Today we are doing a visual inspection and bony palpation of the foot. We have liquored up. We already have a relationship. We don't have to do introductions. I do need permission to touch. Nate, we're going to do a visual inspection. We're going to look at and feel the bones of your foot. May I have your permission to do that?
You do.
If I do anything that makes you uncomfortable, just suck it up. I mean, let me know what you're feeling, okay? This isn't a professional video. I can do me. So, with visual inspection, when the client first walks in, you will watch their gait. We've talked about gait. You're going to look for fluidity, symmetry, posture, proportion. If you notice something's not fluid, you'll start watching the gait phases, stance phase and its various subportions, and swing phase, and then start breaking it down with Einmann's 7 plus 1, Boyer's plus 1, so we'll call it Einmann's 8, and that plus 1 is equal stance phase time. Okay? And we'll have them weight bear here in a few minutes. First thing we want to do, he wore sandals today, so we'll use my shoe. Hoppenfield does a good job about talking about the shoe. You can do a lot of diagnosis with just the client's shoe. If a person, we normally, I'm going to use your lap, heel strike, slightly posterior lateral. The shoe should be more worn on the posterior lateral aspect, and then up the lateral ball of the foot and off the toe. Because we heel strike, roll up the lateral foot, and then the toes come straight off like this in the push-off phase. If the toe is scuffed a lot, you may well suspect a drop foot. Now it's going to be an advanced drop foot because this person will have to do the steppage gait. If they can, when they come toe heel off, we naturally concentrically dorsiflex to clear the toes and swing through. If they've got an advanced drop foot, they can't dorsiflex, so those toes will drag and they'll scuff their toe during swing phase, which is called steppage gait. So this is the last to come off, it's the first to touch down, and then we drop down again. Scuff toe. If it's less advanced, like my personal case, I can dorsiflex so I can clear the foot. There's enough weakness when I heel strike, the foot slaps to the ground slightly. That's called drop foot. The condition, the weakness of the dorsiflexors is drop foot, but when we clear the toes by hip hiking, we call it steppage gait. So a worn out toe, you're suspecting a weak dorsiflexor or swing phase or stance phase of drop foot. If the shoe has when we roll off of our foot, we should come straight off. We should have a transverse crease in the shoe. If the shoe happens to have an oblique crease, this indicates one of several things. They don't want to come off the toes or the great toe, or they don't want to bear weight on the metatarsal heads. So we could have hallux rigidus. They're going to come off the lateral foot, which makes an oblique turn. They may have metatarsalgia, general pain across the metatarsal heads, or they may be toeing in when they walk, which makes them come off the lateral foot, so it is oblique, or it may also be a Morton's toe, which is a ganglion that's been traumatized, usually between the 3rd and the 4th digit right at the metatarsal heads. Okay? That's if you have an oblique crease across the shoe. If they're worn laterally, then they likely have a pes cavus, which is a high arch, a caved arch here. If the shoe medial border is broken down, you'll see bulges here, or it's worn out, and or they're wearing the medial side of the shoe, then that's because they've got a flat foot and they're wearing this part of the shoe, and the medial arch in the shoe will break down. So things that you can see and recognize, if they're not worn here at all, they're not doing a proper heel strike, and or they might be doing, if it's not worn at all anywhere, a calcaneal gait, where they don't want the plantar flex to push off, so the foot comes straight up and it comes straight down. So they just wear the entire plantar surface of the shoe. Very well. So you can assess the shoe there. I like it that way, so I'm going to kick my other shoe off as well. When the client walks in, watch how they walk. You're looking for fluidity, symmetry, posture, proportion. Color here is a significant factor. When the foot is elevated with your permission, let me go with this one. When it's elevated, like we do see here, we should have a light pink color. Some people, when we drop the foot down, this is called, and I hold you for it, the dependent position. When you're sitting in an airplane, when you're sitting in a chair, you're in the dependent position. Some people, because of circulatory problems, their foot may well turn bright red, rubor in Spanish, like the symptoms of inflammation, calor, tumor, rubor. Anyway, this is called dependent rubor, or in the dependent position, the foot is bright red because of vascular problems in the feet. When the person is weight bearing, it should push some of the blood out of the foot, and especially on the weight bearing surfaces, you might even see white, and that's normal and natural. That's what we want. As you visually examine the foot, you may see a lot of trauma and wear on the feet. So if they have abnormal wear or excessive wear in some areas, like the weight-bearing spots, base of the fifth metatarsal, metatarsal heads, the plantar surface of the heel, if there's a lot of callousing taking place, then for some reason they've got excessive wear taking place, and you'll want to find the source for that. Why are they bearing so much weight in one spot rather than the other? There's a lot of fat pad and aponeurosis and things to transmit the weight through, and it shouldn't be localized on one spot. When you operate a shovel in the summer, you get your calluses because all of the friction is right there. Likewise, something's going on with that here. With visual inspection of the foot, we want to see a normal longitudinal arch here. What is normal? Well, if the arch is a high cave, we call it pes foot cavus, a high cave. I'm not going to go into diagnosing that right now. We do that with special tests later in this chapter. But it's a high arch, and that can lead to problems all the way up the skeleton. If the arch is collapsed, they bear a lot of weight here. You see a lot of the foot tissue down in here, pes plantus, or flat foot. Normally, we want the navicular tubercle, that landmark right there, in the middle third. If you divide the foot into thirds, 1, 2, 3, you want it in the middle third. The lower third is pes planus. The upper third is pes cavus. This is natural right here. So you want to see a normal dome of the arch. We may see in a youngster, may I bring your foot around? Well, I'll do it with this. In a youngster, you'll often see the hind foot and the forefoot is adducted A44 in. That's a common thing with a youngster, pre-walking, even pre-cruising the furniture, holding onto the couch and the furniture and sidestepping. And then weight bearing will correct that often. A test for that is you can fix the plantar surface of the hind foot and just try to adduct the forefoot, and it will go back to neutral. That right there is normal. If you may see when the person is standing a calcaneal or heel valgus. The Achilles is all telling. If they've got an everted foot, we'll have a bowing medially, a calcaneal valgus. If it bows laterally, we have a calcaneal varus. And that's all telling to start looking for something else going on. We've already talked about in the foot, with swelling. If you have a localized swelling, then it's usually due to some kind of trauma. And it's usually found around the medial malleolus, secondary to an inversion sprain. No, it's usually around the lateral malleolus, secondary to an inversion sprain. We invert mostly because the deltoid ligament here is much larger and stronger. It prevents eversion. The fibula is longer than the tibia, descends distally, more distally further, and it's also slightly posterior. This is to create the mortise we need to do the dorsiflexion we need. We'll talk about that later. But we can invert and we get bony, because this is longer. If we evert, we get bony obstruction sooner. If we invert, you get medial malleolus on the talus or the calcaneus, and we're bony obstructed and prevent the E. No, it allows the inversion. I'm really messing you up. Long fibula prevents eversion. Therefore, we have more inversion. Strong deltoid prevents eversion. Spindly three little ligaments here allow inversion. The bow of the Achilles, localized swelling usually here, it means secondary to trauma, and it's usually a sprain. If it's unilateral. If it's bilateral, we want to be suspecting some kind of cardio condition or a lymphatic condition. Remember, the right heart receives fluids from the body. If the right heart is weak, fluids will back up because the right heart can't handle whatever is coming to it. Okay? Left heart handles blood returning from the lungs. And if it's weak, we'll get fluid in the lungs. And that's beyond the nature of this course. So if you see bilateral edema, we're thinking vascular or lymphatic or cardio conditions, and you'll want to follow through with that. It's not just something going on in the ankle. Very well. Other conditions of a youngster that you can look for: forefoot adduction and calcaneal valgus and varus, generalized versus localized edema, dependent rubor, pes planus or pes cavus. Having said that, we're ready to move on to bony palpation of the foot. Okay, we're going to have the foot. I'm going to start with the foot up on my lap here, so you have a medial view. And again, some of the landmarks are, or the zones are just one simple landmark. Looking at, Hoppenfield does a very good job with his diagrams like always. I'm going to look at something one moment. Oh, there's something I missed. That's what I was feeling. Yeah, when the person first sits down, I'm going to have you just relax and let your feet dangle, please. They should be in a plantar flexed. That's a grade 3 rupture right there of the flexor hallucis brevis. So the foot should be slightly plantar flexed and inverted for a normal resting, relaxed position. If they are otherwise, then it's likely pathologic. You may see at times a dorsiflexion and eversion. This is spastic flat foot is what it's called. Remember, the person that's flat-footed walks on the medial arch, so they're everted, but it'll often be dorsiflexed. Now we have muscles in spasm, spastic flat foot. Hoppenfield describes the first page of that unit. With the bony palpation, I referred you to page 200 and 201. Hoppenfield has a nice chart of the anatomy, and so you can use that for your sketches, and everything's labeled and diagrammed well and walks you through the assessment. First place we start is the metatarsal phalange joint, MP joint of the foot. With this, notice I automatically look up at his countenance, have him relaxed. I would expect to see a little whiteness down in here from weight bearing, but not completely. And I'm just palpating around the proximal phalanx and the first metatarsal. Tarsal is with the toes, carpal is drive the cars. So just palpating here, nothing particular. It should flare out at the distal end and it should not be painful. While I'm here, I'm going to go ahead and do the sesamoid bones on the plantar surface. This is the last thing Hoppenfield comes to on the plantar surface, but while I'm here, I'm going to do it anyway. Sesamoid bones are typically a bone that are inside a tendon. They're to disperse weight bearing and or allow a tendon to fulcrum glide over an angle. So we do bear a lot of weight right here on these sesamoid bones. You don't really feel them. You're just on them on the plantar surface. And if they're pathologic at all, it'll elicit tenderness. Okay? Metatarsal phalange joint. Really feel every aspect of the metatarsal as you move proximally. And then like here, it flares out again, ever so subtly. You've got to really tune in the ears on your fingers, and it flares out. This is the proximal end of the metatarsal, and then there's a very subtle, you can see that I just barely move in there, the first metatarsal cuneiform joint. I'm going to strip this down so you can see it more. There's the plantar fascia aponeurosis, thank you. There's the flexor digitorum brevis. There's the flexor digiti minimi. That's the flexor digitorum brevis. That was a flexor hallucis. So now we're coming up to, you see this capsule, diarthrodial joint. It is a gliding joint, not so important to me right now because it's part of a metatarsal and they are gliding joints. First metatarsal cuneiform. We're going to locate that spot, very subtle where the metatarsal flares out, and then you're on the first of 3 cuneiforms. Moving proximal to that, I'm going to the navicular bone. Be aware that this articulates with 5 bones. This is kind of the keystone of the foot. The keystone is the stone at the top of the Roman arch that supports and the entire arch. You remove the keystone, the entire arch collapses. Likewise with the navicular. Anteriorly, we have the first cuneiform. Posterior, we have the talus and the calcaneus, and then laterally, we have the cuboid that it articulates with. On the navicular, there's a little bimp. That's the Pink Panthers term for bump. Right here, it's prominent. Okay? First metatarsal cuneiform. You don't distinguish between the cuneiform and the navicular, but you can rub the medial arch, and there's the navicular tubercle of the navicular. Okay? That's a prominent landmark that we'll come back to with soft tissues. From there, we can eyeball and move right to the medial malleolus. Excuse me. Palpate the entire medial malleolus and go proximal. It's the tibia, so like the ulna, it's subcutaneous all the way up and back down. From the medial malleolus, I'm going to step to the inferior aspect and then drop off distally. There'll be a little dent there, and then you can, with some pressure, you'll find a bony landmark again, and then it steps off to fat pad and soft tissue. This bony landmark is significant, is the sustentaculum tali. You've got the talus and then the calcaneus, and a big bridge comes out off the calcaneus because a lot of the talus hangs over the medial arch and it's not supported if that sustentaculum tali is not there. Sustentaculum tali, can't see it, it's covered with soft tissue, but it's this prominent bridge or arch that sticks out that supports the talus. Okay? So when you orient the 3, sustentaculum tali, you step off into soft tissue. Anterior to that is the navicular tubercle, and then up here is the medial malleolus. Okay? They don't make an isosceles or anything like that, but 3 significant bony landmarks. Between the sustentaculum tali and the medial malleolus, we'll move posterior on the heel, I'm not able to say the talus or the calcaneus, I think it's the calcaneus, is the the medial tubercle of the calcaneus. I'm embarrassed and I apologize, but I'm going to see which it is. Medial tubercle of the talus. Okay. So bony landmark, bony landmark, bony landmark, and then a fourth one back here. Like the adductor tubercle on the medial condyle of the femur, okay, you'll have to put your finger behind it and hook it and then roll back and forth. That's a significant bony landmark there. One more thing on the talus, coming back, when you go from here to navicular tubercle, there's a drop off, soft tissue right in here, between the navicular tubercle and the medial malleolus. Put your finger there and plantar flex and invert. Your finger dives way in like the olecranon fossa. You can see how far I go. When you evert, it pushes my finger way out. You see the difference there? That is the head of the talus. You're manipulating the foot so that the talus is becoming very prominent out under the skin. That is actually the bone that breaks down the medial arch of a shoe if a person's got a flat foot. Because the navicular tubercle will collapse, the spring ligament is sprung between the sustentaculum tali and the navicular tubercle, and then the talus will collapse medially, and that breaks down that medial arch of the shoe. So we've named the bony structures here. From here we're going to go to the lateral aspect of the foot. We don't assess anything dorsal other than you might just brush through the foot real quickly, but Hoffmanfield doesn't even speak to it. On the lateral aspect, we're going to orient on the lateral malleolus, which is the fibula, a non-weight bearing bone, like, oh no, I won't compare. It dives deep into a lot of tissues like your radius does. So you can't follow it all the way up, but I can surely palpate it down here. From the lateral malleolus, I will go to the styloid process of the fifth metatarsal. You can see how prominent it is there. Lateral malleolus, styloid process of the fifth metatarsal. Steps off to a lot of soft tissue, so you can easily locate that there. We commonly fracture that by landing on the lateral foot or doing an inversion sprain and rolling over on it, or the peroneals coming down, peroneus, tertius, and brevis, attach on the styloid process. We will do an avulsion fracture. With a forced inversion sprain, the peroneal's myotatic response will contract to protect, and it'll actually pull the styloid process off of the fifth metatarsal. Or you may roll it and break it right there. We call that a Jones fracture. Lateral malleolus, styloid process. Palpate along, there's a lot of soft tissue. It's not subcutaneous, but you are on the lateral border of the calcaneus. When you get inferior to the lateral malleolus, you'll come up from the calcaneal plantar border up into, split the difference, and over here there is a tubercle called it's just a little bimp like the epicondyle on the condyle of a femur. It is the peroneal tubercle. Your peroneus longus and brevis. Come, please, plantar flex and evert. There, you see him stand out. How did I know to do that? Not because I memorized what the peroneals do. I know they pass behind, so I'm going to plantar flex, and they pass lateral to an anterior-posterior axis, so they will evert. Because I know where they lie, I know what they're going to do, I have him do it, they stand out. And here, you can see the peroneus brevis. And down here, that's a blood vessel, but they'll come down, and this peroneal tubercle bifurcates them. Ooh, there's a fancy word. Makes them split. A blood vessel bifurcates. A bronchial branch bifurcates. So that peroneal tubercle causes them to peel off, and the long head of the peroneus longus actually goes through the arch and clear around under the arch and attaches clear over on the medial side of the arch. It serves as a stirrup, supporting all of these soft tissues up in here and supporting that longitudinal arch. Perineal tubercle, okay? From the perineal tubercle, we're going back to the lateral malleolus, and then, like we found the head of the talus by plantar flexing and inverting, dorsiflexing and everting, likewise we can find what is called the dome of the talus. Here, it is also called the sinus tarsi. Do you know why? Sinus is hole or cavity in the tarsals. It's the big deep spot right there. That is actually the tibiofibular joint, talofibular joint. And in soft tissues right there, you can't distinguish. On the floor, you're on the talus and the fibula coming together. That, do I go there? That's the first ligament that goes when you inversion sprain. After you take that one to a 2, the lateral calcaneofibular starts as a 1. And after you take this to a 3, and that's a 2, then the posterior talofibular goes. But they're spindly little ligaments. In the floor of this sinus, you can plantar flex and evert again. Not as prominent, but you'll feel the dome of the talus come out into your finger. You can be doing these right now with your own foot. I should have said that in the first place. There's the dome of the talus. Would you try that on yourself? Locate the dome of the talus. Kind of tough to do. Sitting on a bench. There. As you move it, you'll feel the bony prominence stand out, just like the head does over here. So, 5th metatarsal styloid process, calcaneal plantar border, lateral malleolus, perineal tubercle, sinus tarsi, that is the distal talofibular ligament. Yes, and the dome of the talus. Let's get back here in the camera. From here, we're going to the posterior heel, where we travel around with both sets of hands, both hands, and we're on the calcaneus. Subcutaneous, you can feel the soft tissue here. We'll do that later. But you want to get all around on the calcaneus. It is subcutaneous. You can feel it all around, except for where the soft tissues tie in on the dome of the calcaneus. From there, we're going to go to the plantar surface. Let's go with your foot over here, please. And slide back, and I'm going to swing it around here. Back a little further, please. Thank you. The plantar surface. Lots of trauma, 2,000 PSI with walking every time you heel strike. Up through the fat pad, the calcaneus, the talus, the tibia, on up through the skeleton. So we have a lot of soft tissue to protect that. Again, I'm going to look for callousing. If there is callousing, then they're bearing too much weight in one localized spot. The tissue, the simple squamous epithelium, the epidermis says, whoa, we're getting too much trauma, we better heal. And it lays down more callousing. And it becomes callous because it's removed further from the blood supply, so it becomes somewhat keratinized, which is your fingernails, is just epithelium that's keratinized. So it becomes protective right there. Look for that for abnormal weight bearing. Looking at the arch, we should see a high arch here, the medial arch, and we have a longitudinal arch. We have a transverse metatarsal arch, just for normal. With palpation, not a lot you can feel, but right foot, the calcaneus has one little spot right over here. All you feel is fat pad, and then it steps off. That is the medial tubercle of the calcaneus. Significant landmark for the plantar fascia, the flexor pollicus brevis, the flexor digitorum brevis. A lot of soft tissues attached right there. If you suspect plantar fasciitis, just the TPT test, like tennis elbow, jumper's knee, you can push right there. Yep, that's the spot, because the stress will be on the tubercle. It's soft tissue, step off. Then you're on it. From there, we're going to go up along the shaft of the fifth metatarsal to the metatarsal heads. Shouldn't be able to see them real well. Do note that they are further, they're not in the webbing of the toes, they're further down in. Where they're right at the top here, but down here, they're clear down into here, so make sure you're feeling those metatarsal heads. You can't isolate the metatarsals on the plantar surface, but you can on the dorsal surface. And you're just looking to elicit tenderness and palpating the proximal, middle, and distal phalanx of each toe. You've already done a visual on them. And again, keep in mind that the great toe or the hallucis only has a proximal and a distal. Like the thumb, proximal and distal, it doesn't have proximal, middle, and distal. Palpating the plantar surface of the metatarsal heads, and that is the visual inspection and bony palpation of the foot. Thank you for your attention. Get the sequence down from Hoppenfield and the exits as you're coming to them, mental practice, and then you can practice on yourself lots and lots because it's easy to access each of those landmarks, and you can get those bones down quite quickly since you already know the anatomy. It's just what exit comes next. And a few manipulative things you do to make them stand out. Thank you for your time. Good luck with your studies. Go ahead, Nate, if you would.